In this particular section, we are going to discuss on a topic called hyperpituitarism. We already discussed hypopituitarism in the previous chapter. So whenever you call the word hyperpituitarism, we have to discuss on a topic called pituitary adenomas. So in this particular section, we will be discussing an overview of pituitary adenomas, but not in depth about the individual pituitary adenomas, which I'm going to do from the subsequent videos. At the same time, this video will also cover some of the differential diagnosis for the mass lesions that are present in and around the pituitary region, that is near the cellular and the supracellular region. So let us move on. So we are going to discuss on overviews of pituitary adenoma. Why pituitary adenoma is very, very important? Because it contributes to a sizable number of primary intracranial neoplasms. That is approximately 15% of the primary intracranial neoplasms are pituitary adenoma. So which means almost 1 in 6 to 1 in 7 of the intracranial neoplasms tend to be pituitary adenomas. And pituitary adenoma, you know, it's a cellular tumor. There is no need to introduce about that. Pituitary is a gland of the cella turcica. So the tumors of the pituitary will be a cellular tumor only. Okay. So what is the age group where pituitary adenoma tends to happen or tends to occur predominantly? It's approximately in the 35 to 60 years age mark. So that's where you're going to get the pituitary adenomas very, very commonly. So which means it's not so old, not so young, somewhere in the middle age group to a little old age group. That's it. So similarly, pituitary adenomas are mostly sporadic. Almost 95% of the pituitary adenomas tend to be sporadic, which means they are not inherited. But 5% of the pituitary adenomas, a very less number, almost 1 in 20 pituitary adenomas can be familial as well. Familial in the sense they will be associated with a very, very important endocrine syndrome called a MEN1 syndrome. Clear? So you know MEN1 syndrome is due to MEN1 gene mutation on the chromosome number 11, where you're going to have 3 different tumors predominantly. All are 3 Ps. We know that it's a pituitary adenoma, parathyroid adenoma, and a pancreatic neuroendocrine neoplasm. So these are the 3 Ps, 3 endocrine tumors that happen with MEN1 syndrome. At the same time, you have to classify the pituitary adenomas also. So let us see the classification of pituitary adenomas. Classification wise, you can classify the pituitary adenomas based on the size, or you can classify the pituitary adenomas based on the functional status, functionality. So based on the size, I can classify pituitary adenomas into those tumors that are less than 1 centimeter in diameter, or those pituitary adenomas that are more than 1 centimeter in size. So less than 1 centimeter pituitary adenomas, we generally tend to call it as a microadenoma. More than 1 centimeter pituitary adenoma, we tend to call it as a macroadenoma. One of the major differences between a microadenoma versus a macroadenoma is the mass effect that is produced by macroadenoma. Generally, a microadenoma will not produce any mass effect. There's a very, very important difference. You know what are the mass effects in the pituitary? We have discussed already in the hypopituitarism. First one is going to be the headache. Headache is a very non-specific mass effect. It can happen in any intracranial tumors or anything that raises the intracranial pressure. Second, you can get visual field defects. Typically, you know, they are going to result in bitemporal hemianopia, where superior vision will be affected more than the inferior vision. We have seen this already. And number 3, you can get hypopituitarism, which can be relative hypopituitarism. I told you already. So the tumor can produce a particular hormone in excess, but they can compress on the adjacent normal gland, and they can reduce the synthesis of other hormones that are produced by the other acinar cells in the pituitary. So really, really important. So they can produce a relative hypopituitarism. And next, you can get cranial nerve palsies. This is very rare. Usually you encounter the pituitary carcinoma more than adenoma. Cranial nerve palsy, whenever the tumor is going to invade into the cavernous sinus. So you're going to get cranial nerve palsies. All right. Or very rarely you can even get hypothalamic involvement, but that's too big a tumor to enter into the hypothalamus and produce the effects on the hypothalamus. That's really, really not a feature of a pituitary adenoma, but very rarely it can happen because of such huge tumors. And similarly, based on the functional status, based on the functionality of the tumor, you can divide into a functioning pituitary adenoma and second one, a non-functioning pituitary adenoma. Non-functioning pituitary adenoma. The functioning tumors are also referred to as a not so good name called as a secretory tumors, and non-functioning pituitary tumors are also called as non-secretory adenomas or non-secretory pituitary tumors. And again, these names I don't use really because they don't actually reflect what they are doing. So, but the right term will be the functioning and the non-functioning tumors. What do you mean by the functioning tumors? Functioning tumors means they do secrete some functioning hormones. Clear? They are going to secrete some functioning hormones or secrete a functioning hormone. And this hormone may or may not have peripheral effects, that is different, but they secrete some functioning hormone component. Clear? But whereas a non-functioning pituitary adenoma will not secrete any functioning hormone, does not secrete any functioning hormone, which means they can secrete bits and pieces of a particular hormone, but that is not functional, or they cannot, or they do not secrete anything at all. That's also a possibility. So which means these do not have any peripheral effects at all. They cannot have, because they don't secrete any fully functioning hormone. They can secrete some bits and pieces, all right, or they do not secrete anything at all, but they don't secrete any functioning hormone in the first place. So this is how you divide based on the functionality. But to be honest, a microadenoma can be functional or non-functional, but very commonly it will be a functioning tumor. Why? If they are going to present at a microadenoma stage, they should present with some hormonal effects in the periphery. That's why they come to the hospital. That's why a microadenoma generally tends to be functioning. Whereas a macroadenoma can be again functioning or non-functioning, but it generally tends to be non-functioning, because for a macroadenoma, for a non-functioning tumor to produce symptoms in the patient, they do not generally produce due to this hormonal effects, but they generally tend to produce through this mass effect. So that's why macroadenomas generally tend to be non-functioning, but not always the case. But you can classify pituitary adenomas based on the cell of origin. So what is going to be the cell of origin? First, let us see something called a lactotroph adenoma. Lactotroph adenoma is otherwise called as a mammotroph adenoma, which is otherwise referred to as a prolactinoma, because they are going to secrete prolactin. So that's why it's also called as prolactinoma, and the clinical features will be due to excessive prolactin secretion. Typically, excessive prolactin tends to cause a gonadal dysfunction, which we'll discuss in detail in the prolactinoma section in the next video. But how much this prolactinoma or lactotroph adenoma is going to contribute? It's going to contribute to approximately 45% of the pituitary adenomas, which means it's the most common pituitary adenoma. Fine. Then second one, you have a gonadotroph adenoma. Gonadotroph adenoma. What gonadotroph adenoma is going to secrete? Nothing. They can secrete some bits and pieces of like your gonadotropins, but they do not have any peripheral function. So it's like a non-functioning tumor. So gonadotroph adenoma generally tends to be non-functioning. They do not secrete any particular viable hormone into the blood. So it contributes to approximately 40% of the pituitary adenomas, which means it's the second most common tumor among the pituitary adenomas. So I can write functioning tumor or overall most common pituitary adenoma tends to be prolactinoma. Very important point. Similarly, the most common non-functioning tumor tends to originate from a gonadotroph adenoma. This is the origin for the non-functioning tumor most commonly. Remember, functioning tumors are more common than non-functioning tumors. You know that because only 40% are non-functioning, which comes from the gonadotrophs. Remaining 60% are almost functioning tumors only. Okay. Then third one, you can get with somatotroph adenoma. You know, somatotrophs, they're going to secrete growth hormone. So they produce excessive growth hormone. That's why this is also referred to as a GH secreting pituitary adenoma. And they contribute approximately 15% of the tumors, pituitary adenomas. And next you have a corticotroph adenoma, which is nothing but they're going to secrete ACTH. So it's also referred to as a ACTH secreting pituitary adenoma, which means they are going to increase the cortisol, which means it is one of the important causes of secondary hypercortisolism, which means ACTH also increases, cortisol also increases. This is secondary hypercortisolism, which is going to cause Cushing's syndrome. But remember, an ACTH producing pituitary adenoma, that is a corticotroph adenoma, it's also referred to as something called a Cushing's disease. Remember, Cushing syndrome due to corticotroph adenoma is what we refer to as a Cushing's disease. Then you can have a thyrotroph adenoma also. Thyrotroph adenoma tends to have excessive TSH or TSH producing adenoma. It can be called as TSH producing adenoma also, where they're going to produce excessive thyroxine, which means again it's a secondary hyperthyroidism or a central hyperthyroidism. That's what you're going to get. So this is also referred to as a TSH secreting pituitary adenoma. What is the percentage? Almost 5% are ACTH producing tumors and less than 1% are the TSH producing tumors, which means if they ask you among the pituitary adenomas, which is the least common or rarest form, you can tell it's a TSH producing pituitary adenoma. It's very, very, very rare, less than 1%. This is how you classify based on the cell of origin of a particular pituitary adenoma. Then let me put a table. So you have secretory tumors and you have non-secretory tumors or non-functioning tumors. Then I can write here microadenomas. I can write macroadenomas here. Secretory microadenomas generally tend to be symptomatic very, very commonly, but rarely they can be asymptomatic also. I already told you microadenomas do not produce any mass effect. So which means why they are symptomatic? Which means these symptoms must be due to hormonal oversecretion, right? But on the other hand, non-secretory microadenomas generally tend to be asymptomatic. They do not tend to be symptomatic at all. Whereas secretory macroadenomas, they usually will be symptomatic. Why? Because they tend to produce this hormonal oversecretion. The secreting macroadenomas, they tend to produce symptoms due to hormonal hypersecretion or hormonal oversecretion. At the same time, these macroadenomas tend to have mass effects also. So definitely they will be symptomatic. Similarly, a non-secretory tumor, macroadenoma, generally tend to be symptomatic, not due to hormonal oversecretion, but by virtue of mass effect. Clear? But they don't have any symptoms due to hormonal oversecretion, which means this secreting pituitary adenomas will have hormonal hypersecretion, whereas non-secretory adenomas will not have any hormonal or functioning hormonal oversecretion. Clear? So this is how you know about the pituitary adenomas. So now let us go to the investigations. What you're going to do for a pituitary adenoma. So what are the investigations you're going to do for a pituitary adenoma? Investigation wise, you can do hormonal assessments. You can do hormonal assays. Directly you can measure hormone. For example, you can do for prolactin, no problem. For prolactinoma, you can check for the prolactin directly. Or you can do a lot of other tests like suppression test or stimulation test. So stimulation test we do in deficiency purpose, but we are trying to have excess, detection of excess, isn't it? So you can use this suppression test also. Typically we use for growth hormone secreting pituitary adenoma. Like we use the oral glucose tolerance test, which is one of the suppression tests that we prefer for diagnosing excessive growth hormone production. Let us see in subsequent videos about all those. So you can use hormonal assays or you can use this suppression tests also. So, but the radiological investigation of choice, if they ask you, it's always the MRI. MRI is going to be the radiological investigation of choice for any kind of pituitary adenoma or even a suprasellar tumor like a craniopharyngioma. So let us see what you will see in the radiology. Let me load the image. Okay. So what you are seeing here is the different anatomical structures. First thing you can delineate and clearly you can tell this is a T1 weighted image because the CSF is black. So T1 weighted images are important for delineating the anatomy better. So that's why I'm using this T1 images. You can see this is the pituitary area, right? which is just above the sphenoid sinus. Clear? This is just above sphenoid sinus. This is a pituitary area. That's a pituitary gland that you're seeing. And you can also see this is the pituitary stalk. And you can also see that this is the optic chiasm. Clear? Above that, you're going to have the hypothalamus, optic chiasm. And you can also see this is the internal carotid artery in the cavernous sinus. Clear? And this is the coronal plane. You can see that in the sagittal plane also, where you can see this is going to be the pituitary. And very importantly, you are seeing one bright spot in the posterior aspect of the pituitary. This is a very, very important anatomical landmark. This is nothing but, this is called a posterior pituitary bright spot. Whenever you see the posterior pituitary bright spot, it indicates that the posterior pituitary is functioning normally. Very, very important point. I'm going to use this in diabetes insipidus differential diagnosis. That's why this point is really, really important. And next, you can see the sphenoid sinus as usual here. That's why this sphenoid is a very important landmark, because just above the sphenoid sinus, you have the pituitary. There are two importance of that. In exam, it's very easy to identify a pituitary adenoma, which will be just present above the sphenoid sinus. And at the same time, you have transsphenoidal approach to go to the pituitary and remove the tumor, isn't it? So that's why these are really important to know, the sphenoid sinus landmark. And you can also see this is the pituitary stalk that's attached. At the same time, you can also see this is the optic chiasma. Clear? So you have a lot of stuff to know. So this is the landmarks in the sagittal section, but at the same time, I want to tell that this pituitary bright spot, the posterior pituitary bright spot, is the most important landmark as far as I know, especially in the sagittal section. You're not going to see this in the coronal plane. You're going to see this in the sagittal plane very nicely. Okay. Now let us see how does a pituitary adenoma look like. Obviously, you're going to look for something above the sphenoid sinus. You can see this is the adenoma here. This is a T1 weighted image, where the adenoma looks a little bit hypointense and the surrounding is the normal pituitary. You can see. Similarly, you can see this is a T2 weighted image where you can see the adenoma little bright and white. So this is the tumor here. And you can see surrounding normal pituitary, which is hypointense. So this is the normal pituitary surrounding. Clear? So this is again a very, very important image for the exam. So they might ask you about the pituitary adenoma. So you have to know about this. Then they will ask you one more question in the exams: how to differentiate between an adenoma and a simple hyperplasia. So for that, you need to again know an image, which I'm going to load now. So this is an hyperplastic gland, or even a normal gland will look like this most of the time. And this is an adenoma. This is a adenoma for sure. So how to differentiate? There are two ways to differentiate. One is by putting the reticulin stain. So what you are seeing is the reticulin stain. So when you put the reticulin stain, you can see that they have a good reticulin bridge. Clear? And the reticulin network is continuous. You can see this borders, the reticulin network is literally continuous. Clear? So here the reticulin is continuous. Whereas if you see in the pituitary adenoma, this is the adenoma area, where you can see it is disrupted. It's not continuous at all. You can see this black dots on the reticulin. So you can see the reticulin is not continuous. Instead, the reticulin is disrupted. Reticulin network is disrupted here. Second one, you can see here there is a compression of the adjacent normal acini. Compression of adjacent normal acini. But here you don't see anything like that. So you don't have any compression of the adjacent normal acini. So these are the two very, very important and solid points that you have to know to differentiate between a pituitary adenoma versus a hyperplasia. Very, very important in histology. Okay. Then finally, we wanted to discuss on the differential diagnosis of the pituitary adenomas, or differential diagnosis of tumors in and around the cellular area, or mass lesions in and around the cellular and supracellular area. Okay, differential diagnosis. DD wise, the number one DD that you have to discuss is on the craniopharyngioma. Very, very important DD. First of all, you have to know that this craniopharyngioma is a supracellular tumor. It's not a cellular tumor like pituitary, it's a supracellular tumor. Clear? Very commonly, it will be near the pituitary stalk. Its origin will be near the pituitary stalk, but above the optic chiasma. That's very, very important. I'll tell you why, because one important mass effect is that will lead to a different visual field defect in case of a craniopharyngioma. Number two, where it is originating from. You know it's a benign tumor, craniopharyngioma. It originates from the remnants of the Rathke's pouch. Remnants of the Rathke's pouch. We know where Rathke's pouch is. Rathke's pouch is a upward extension or upward pouch-like structure that is going to arise from the pharyngeal ectoderm in the embryonic period. So this connects with the downward pouching of the hypothalamus or diencephalonic structure to form the posterior pituitary, and both combine to form the pituitary. Clear? So if there are some parts of the Rathke's pouch which are not contributing to the anterior pituitary or adenohypophysis, that can result in formation of this craniopharyngioma. All right. So that is the idea. It's a remnant of the Rathke's pouch. At the same time, they can produce mass effects. Let me come back to it. They can produce mass effects. All right. But it again depends on where it's going to produce mass effect. Remember, mass effects they can produce in the supracellular area itself, or mass effects they can produce through intracellular extension. Mass effects they can produce by intracellular extension. They can come into the cella. Basically, this is a supracellular tumor that can, enter into the cella by virtue of that growth of the tumor. So let me draw the pituitary, and here is the optic chiasma for simple understanding. And you can draw the tumor to be somewhere here in the stalk of the pituitary, where the tumor tends to grow towards the optic chiasma and into the anterior pituitary. But let us see. First, you can very clearly see that the tumor is going to affect the optic chiasma from the top. So since they are compressing from the top, they're going to affect the superior fibers. These superior fibers, I told you, they're going to carry information from the inferior part of the world. So that is the reason why they will also result in bitemporal hemianopia. That is because of the chiasmal compression. But they will result in inferior vision loss more than superior vision loss. That is because of the superior chiasmal compression. Pituitary adenomas cause inferior chiasmal compression, which is going to cause more of a superior vision loss more than inferior vision loss. But this is different. They're going to produce bitemporal hemianopia, that is going to cause inferior loss more than superior loss. At the same time, they can extend into the hypothalamic region also. They can extend their compression towards the hypothalamus also, where they can produce problems like severe obesity due to hyperphagia because of the eating behavior change. So let us see. In the supracellular area, they can compress on the optic chiasma and they can produce visual field defect, where they're going to produce bitemporal hemianopia, which is inferior loss more than superior loss. And second, they can compress on the hypothalamus, which can result in problems in the eating. They will change the eating behavior and they can produce hyperphagia, and because of that, they can result in severe obesity or secondary obesity. Or they can result in intracellular extension, where they can produce hypopituitarism. The effects of hypopituitarism are different between children and adults. In children, they generally tend to produce growth failure. But in adults, they tend to produce hypogonadism. Hypogonadism. Clear? So this is really important. Then, what are the types of craniopharyngioma you have? You have basically two types of craniopharyngioma. One is called an adamantinomatous variety. Second one, you have a papillary variety. First, let me tell which is more common. Adamantinomatous variety is more common, 90%, only 10% is papillary. And second important difference is adamantinomatous variety is common in children, whereas papillary variety is common in adults. Which means children are the one who are going to be suffering from this craniopharyngioma rather than adults. And what will be the nature of the tumor? Nature of the tumor tends to be cystic and lobulated in case of adamantinomatous variety, whereas in papillary variety it tends to be solid. But one important point aside with this cystic lesion here is when you break the cyst and take the fluid out, it looks like a motor oil. That acts as a motor oil appearance will be there if you take the fluid out of the cyst from this tumor. And at the same time, this tumor tends to show a lot of calcifications, one of the important childhood tumors that calcify. If they tell you midline calcification in a child is equal to craniopharyngioma. In adults, midline calcification can be just due to a pineal gland calcification. But in children, the midline calcification is usually due to a craniopharyngioma only. It's not benign at all. Very, very important. If they ask you most common childhood tumor to calcify, craniopharyngioma. Most common cause of midline calcification in children, craniopharyngioma. Similarly, most common supratentorial tumor in children, craniopharyngioma, because most of the tumors in children tend to be infratentorial. But if they ask you most common supratentorial tumor in children, that tends to be craniopharyngioma. And usually calcifications are rare, are uncommon, are not present in case of a papillary, adulthood craniopharyngioma. And what is the gene to be mutated? That is CTNNB1. That is the gene that is mutated. That is nothing but a beta-catenin gene, which is important for the beta-catenin pathway. Whereas here it is due to BRAF mutations. We have seen extensively about BRAF in the first video itself, right? BRAF mutations. Finally, what is the cellular appearance, histological appearance? They are going to have this reticular epithelial cells, whereas here they will have metaplastic squamous cells. So you can see all are C's in adamantinomatous variety, isn't it? Children, cystic, calcification, CTNNB1. So a lot of C's are there in this adamantinomatous variety of craniopharyngioma. So you can remember like that also. Fine. So with this, your craniopharyngiomas are done. We are going to discuss again about this craniopharyngiomas and brain tumors in the central nervous system section. Okay. Second one, which can present as mass lesion, is lymphocytic hypophysitis. Lymphocytic hypophysitis. What do you mean by this lymphocytic hypophysitis? It's lymphocytic infiltration of the pituitary, hypophysis. That is what we refer to as lymphocytic hypophysitis. But can they present like a mass lesion? Yes, they can have mass effect, or they may not have mass effect, and they can present like a mass lesion. But what will be the clinical feature of lymphocytic hypophysis? Remember, first of all, it's an infiltrative lesion, which means the pituitary is infiltrated with lymphocytes. Because it's infiltrative lesions very commonly cause posterior pituitary problem than anterior pituitary problem. So you will expect a posterior pituitary problem in an infiltrative disease. Most commonly they will produce diabetes insipidus. But here they cause anterior pituitary problem called as ACTH followed by TSH deficiency. They have ACTH deficiency followed by TSH deficiency. So which means this is one of the very, very few infiltrative lesions of the pituitary to cause anterior pituitary problem than a posterior pituitary problem. Okay, so you may have mass effect, but which are the groups of people who are prone to develop this lymphocytic hypophysitis? One is pregnant women or postpartum women, all right. The second group of people that are very important for exams who can be affected with this lymphocytic hypophysitis is patients who are taking ipilimumab. You know what is ipilimumab? Ipilimumab is an anti-CTLA4 monoclonal antibody. So what is anti-CTLA4? CTLA4 is cytotoxic T lymphocyte antigen. The CTLA4 is something you can think like an immune down regulator, which means it breaks the immunological synapse and prevents the T cell from getting stimulated by the second signal. That's a co-stimulatory signal. So that's what the function of CTLA4. They blocks the second signal. So a lot of tumor cells actually have evolved to secrete the CTLA4 and prevent the immune recognition, that is T cell recognition of the tumor antigens, and thereby will result in subsequent destruction of the tumor cells. To avoid this, they produce the excess CTLA4, which breaks down the immunological synapse and makes the T cells blind, and they cannot recognize these tumor cells. That's why we have devised this anti-CTLA4 monoclonal antibody, that is ipilimumab, which can actually prevent the CTLA4 molecule from blinding the T cells so that the T cells can recognize these tumor antigens and they can produce immunological reaction and they can destroy these tumor cells. Very commonly, this ipilimumab is used for metastatic melanoma. Metastatic melanoma. Clear? So very, very important. So especially when they tell a patient who's on ipilimumab, so comes with like adrenal insufficiency, that's because of ACTH deficiency here. So you can think about lymphocytic hypophysitis. Very important point. Remember, this lymphocytic hypophysitis is completely different to that of a IgG related hypophysitis. That's not the same. You have something called IgG4 related hypophysitis also, where the patient will have hypophysitis due to IgG4 infiltration and plasma cell infiltration of the pituitary gland, where the gland will be infiltrated with IgG4 secreting plasma cells and lymphoplasmacytoid cells. Clear? But other features will be there in this patient, like for example, other events like pancreatitis can be there, or other area fibrosis can be seen in this patient, and the serum IgG4 may be elevated, and ultimately biopsy is the gold standard. But you can see other features, other clues in the exam at least. So this is not the same as IgG4 related hypophysitis. That's what I wanted to tell. Third, we have pituitary mets, pituitary metastasis. Metastasis wise, pituitary metastasis, the breast is the common primary source, followed by the lung. At the same time, you know how they're going to present. They're going to present as diabetes insipidus, and they are going to present as mass lesions. They do have mass effects. Number 4, you have a pituitary carcinoma. There are a lot of features that can be suggestive of pituitary carcinoma. Number 1, they always present as macroadenoma. In fact, a very large tumors like 3-4 centimeter. They always present as a macroadenoma most of the time. And there will be 2 or more hormonal hypersecretion. So that's very classic. 2 or more hormonal hypersecretion. Clear? Multiple hormonal hypersecretion. Then there will be invasion where of the adjacent structures, especially to the cavernous sinus. At the same time, they might invade to the hypothalamus also. So they will have suprasellar and cavernous sinus invasion. So this is again one important feature that will suggest you that it's a pituitary carcinoma. Remember, incidence is very, very, very rare, less than 0.1% among the pituitary adenomas, or among all the pituitary tumors tend to be pituitary carcinoma. Very, very rare incidence. You don't get this pituitary carcinoma often. And finally, you have an entity called Rathke's cleft cyst. Where does this cyst arises from? Again, this cyst arises from remnants of the Rathke's pouch only. That's why it's called a Rathke's cleft cyst. And mass effect, possible but very uncommon. But remember, most of the cases are benign cases and they are detected incidentally. And possible mass effects, I'm not telling always will be there. There might be mass effects if the cyst is very, very huge. And one important question they will ask you in exam, in MRI, what is the pathognomonic sign that is associated with this Rathke's cleft cyst? That is called a large dot sign. That's a very important MRI finding in a case of a Rathke's cleft cyst. Let us see some images. You can see this is a pituitary area or in the suprasellar region, you can see a lot of calcifications because this is a CT image. And you can see these white specks. These are calcifications. A tumor that is calcifying this much must be a craniopharyngioma. And it's a suprasellar tumor. It's a huge tumor actually, craniopharyngioma. And again, you can see this is a childhood craniopharyngioma where you can have this lobulated and cystic appearance. You can see a lot of cysts that are there. And obviously, if you take the cysts out and express it, it's going to show motor oil kind of a fluid. So again, this is a craniopharyngioma. And this is an adamantinomatous type of craniopharyngioma because this has a lobulated and cystic appearance, and you're usually going to see this in children. Then you can see this sign called as large dot sign. So which means this is a patient with a Rathke's cleft cyst. So you can see one important thing, this is a T2 weighted image. Because CSF is white, if it's a T2 weighted image, this water will be looking white, which means the cyst, actual cyst is looking white. The fluid in the cyst is looking white, but you have a hypointense lesion inside the cyst. This is called the intracystic nodule. This cyst with intracystic nodule is the one that makes this look like this large dot sign. The intramural nodule is the one that is creating the dot in the cyst fluid. So in the MRI. So that's what we refer to as a large dot sign. So these are some of the important images that you have to know for the exams. Clear? So with this, I am closing down with the particular section, that is overview of pituitary adenomas and the DDs of mass lesions in and around the pituitary region. In the next section, we can move on to the actual core pituitary adenomas. We'll be discussing one by one. The next video will be on prolactinoma.